Welcome, folks, to another episode of The Wormhole. And not just another episode, we are now in season 3. And I'm so excited for the guests that we have today and the topics that we're going to look at, because it's totally relevant, not just to me, but to you and every single human being out there. And it is such a pleasure for me to have in studio with us today none other than Professor Hariharan Seetharaman. Professor, hello and welcome to The Wormhole.
Thank you very much, Shireen. I am really humbled and honored to be in your show. Thank you very much.
I am so excited and so looking forward to our conversation, because when you find out who Professor Hari really is. So who is Professor Hariharan Seetharaman? Hariharan Seetharaman is a professor of anesthesia and critical care medicine and the director of graduate studies and research at the University of the West Indies, UWI, at the St. Augustine campus in Trinidad and Tobago. He's also a consultant anesthesiologist and intensivist at the Eric Williams Medical Sciences Complex in Trinidad. He has formerly held positions as the Deputy Dean of Clinical Sciences and of Graduate Studies and Research at the Faculty of Medical Sciences, UWI, as well as being the Director of Operating Theatre Services and the head of the Department of Anesthesia and Intensive Care. In addition to his medical degrees, he also has a PhD in health economics. He has published more than 135 peer-reviewed papers and authored chapters in textbooks. He was awarded an honorary fellowship in critical care medicine by the American College of Critical Care Medicine for his outstanding contributions to the field of critical care medicine. He is the recipient of the Vice Chancellor's Award for Excellence in Research in 2015 and the Scroll of Honor from the Trinidad and Tobago Medical Association in 2019. Professor Seetharaman is the immediate past president of Bioethics Society of English-Speaking Caribbean and the immediate past president of the Trinidad and Tobago Anesthesiologists Association. He has held 2 terms as the Secretary of the Medical Council of Trinidad and Tobago. He is the current editor-in-chief of the Caribbean Medical Journal and the chairperson of the NCRHA Ethics Committee. And I can't wait to hear what he has to tell us. So once again, Professor, welcome to the Wormhole, which connects us through space and time. But this is a very small shortcut because we are both in Trinidad.
Thank you again. Thank you very much for having me in your show.
All right, so I want to get started by asking you, we've seen, as I introduced you at first, we see the vast array of things that you've been engaged in. What are the defining moments that brought you to this position?
Okay, I actually was doing my postgrad medicine in Manipal in Karnataka, and at that time, my associate professor was one A.Y. Kumar, and he was a consultant in Barbados. And then one fine morning, I get a call from Barbados asking if you are still interested. So I said, why not? I said, okay. I land up in Barbados. Then I thought I'll go back in 3 years, and I got my daughter there in Barbados, and then when it was 5 years, and then somebody from Trinidad visited Barbados and said, what are you doing in Barbados? Come to Trinidad, you have to be in Trinidad. And then there was a lecturer position available that time, and I joined as a lecturer with UWI. And I just, also completed a PhD here. And then now Trinidad is a very good place. Everybody is so friendly. I see my own home country here in Trinidad. So I'm happy here.
Hari, that's a very interesting story. It reminds me of the words of a song, actually. Life is what happens to you when you're busy making other plans. We are absolutely happy that this is where you are and contributing to enrich this part of the world. All right, so I mentioned in the introduction that your PhD is in health economics. I think not many of us are actually familiar with what health economics is about. Could you tell us a little bit?
And I was always curious as to what are the ways healthcare is provided in different parts of the world. And if you see that way, There are three major ways how healthcare is provided to uh, citizens of every nation. The first thing is a public healthcare system, which can be a government funded system or a pooled fund. In many European countries, they have pooled funds. NHS is a public healthcare system, very strong public healthcare system, and that is the public healthcare system is one way of accessing healthcare. The second way is what we call as the out-of-pocket spending. That is the private healthcare without an insurance, and people have to spend from their own savings or borrow money, and people have borrowed money. And throughout the world, there is a lot of evidence that people have been pushed into poverty and lost every single saving. I know of people right here in Trinidad who lost their lifetime savings. A couple retired as teachers, they lost their lifetime savings in one surgery for the lady, right? And the third one, which is very common in the North American setting in USA, is the third party payer system, which is a monster on its own. Because if you see that way, we have to pay a premium, and we have to claim what we spend for the healthcare, and the hospital establishments and the doctors charge the insurance. There is always what we call as a moral hazard, and there is a lot of inflated expenditure there, and that is why if you see that way, US actually spends 10,000 US dollar per capita currently as it stands. Okay. For the same population health benefits, like for example, life expectancy is one. Okay. And maternal mortality rate is another one. Infant mortality rate is another one. Okay. For the same level or even better healthcare indices, Cuba actually spends only 250 US dollar per capita. And see where Cuba is. And for the same population health benefits, US spends 10,000 US dollar per capita. I compared the resource allocation and the healthcare expenditure for primary healthcare and my own specialty of critical care and high technology cardiovascular care, including angioplasty, stenting, coronary artery bypass grafting, and all that. If we allocate a little more fund towards primary health care, if you strengthen the primary health care, we can get much more population health benefits than the other two levels of care. Because in critical care, since the time I have been here, I've been always telling my colleagues and my junior residents that unfortunately our critical care unit is being used as a launching pad, because people come with very severe critically ill state, and then we try and work with the numbers, we try to treat them with machines, and eventually the inevitable happens. What I'm trying to say is that instead of spending so much in critical care units, so much in the high technology care, if we actually strengthen our primary care and deal with the chronic diseases at the primary level, okay, with relatively less expenditure, we will get the same population health benefits. And that is why I told you the comparison between US and Cuba, 10,000 US dollar, 250 US dollar per capita, and they have the same longevity, same lifespan, same maternal mortality rate, everything is same. So this is what intrigued me, and even though I became a professor that time, in my own graduate studies, they asked me, "What are you going to do with this PhD?" I said, "I'm not going to do anything else other than my own passion, because I wanted to do it and I wanted to know what is the influence of economics in providing healthcare."
The numbers that you quote, Prof, are staggering, the disparity between healthcare in different countries. And as I said at the start, this is a topic and an issue that affects all of us very much. So can you say that doing the PhD in health economics changed the way that you see things, believe?
I mean, I joined medicine when I was 17, and then 22 years I came back as a doctor, and then with all those young, bubbly socialist ideas, I was trying to change the world or whatever. The amount of lives I've saved there, with I have seen patients of meningitis, tuberculous meningitis. They will be brought in coma, and all that we do with the low resources just do what we call as a lumbar puncture. Put in a needle into the back, take the fluid, test it, and simple tests in the lab. And then we know that it is tuberculous meningitis because the proteins will be elevated. And we start them on anti-tuberculous treatment. And they will sit up the next day. So we didn't have critical care unit. We didn't have life support ventilators, nothing of those days. And that is why I'm trying to tell you that, over 30 years, I have seen how medicine has grown and how the commercial influence and the commoditization influence is actually now dominating how healthcare is being provided. And also, there is another major thing throughout the world is the defensive practice. Because people are now with the social media, with the internet and everything, they think that they know a lot of things about medicine, and there is a lot of litigation. And that is when, they have to now the doctors, even though they think that they don't need a scan, they will send them for a scan because somebody will ask, why you didn't do a scan for me? So that is, so defensive practice has gone up, and that actually increases the healthcare expenditure. But I must say that, you will be shocked to know that Institute of Medicine is one of the premier organizations in US. And IOM reports that on an annual basis, okay, at least 1 billion US dollar has been spent in the US healthcare system uh, just because of fraud.
Yeah, from listening to you talk, I realize how complicated and complex this whole scenario is. Absolutely not straightforward. And here you're dealing with human lives. So while it's also very distressing hearing some of these figures, I think from you, Prof, I also hear a message of hope. You stressed that primary care, which for laypersons like myself is an important message to reach, that if we take care of our health with the basic things, that you can be in a much better place than suddenly end up in critical care, which is your specialty. It always amazes me that which every single human being that ever showed up on planet Earth is going to experience, and that's going to be death. Either as you begin to grow older, as I'm experiencing in my own life, people around you begin to die that you've known and that you've loved. And if it's not them, it's going to be you. So it amazes me that it's like a taboo topic, death. And with your wide range of readings and your experiences, and I can see you border on philosophy and ethics and morality, I simply want to ask you, why are we so afraid of death, and should we be?
Okay, thank you very much for that question. And if you ask me what is the mission of my life, is to actually say that, to tell people that death is a natural part of life. Okay. So now you yourself mentioned that nobody is going to get out alive here. Okay, everybody has to die.
Yes, we're all
So
dying to,
yeah. So the
dying
thing
to
is
get
that
out.
what has happened over the centuries is that I must say that Indian tradition where I come from, the philosophical tradition, always considered death to be natural. And my own view of the thanatology, what is thanatology is the study of death, is that I am a collection of molecules and atoms, and and my atoms are never going to die. It may go, when I go in my carbon, my nitrogen will be used by a plant, and then plant will be eaten by a goat, and it's going to be there. And so my atoms will never die. So, but this, whether they want to call it reincarnation, they want to do all that, I don't care about what the spiritual aspects come into that. But death is natural. And it was accepted in the earlier traditions, very earlier traditions, Greek tradition, the Indian tradition, the Chinese tradition. I must say that the over a period of time, when the so-called modern religions came in, So death was seen as a punishment for the sin you have committed. So if I'm going to, punish with death. So death had already that type of a negative connotation. And, it has evolved to this level now at the current generation that, I will say that when somebody dies in a critical care unit, we would have tried everything possible, but still the inevitable happens, right? But it'll create a big ripple. Oh, patient died, patient died, patient died. Why that fear? There need not be any fear about it. What I do in critical care unit is that, when a patient is indeed very, very sick, I talk to the relatives. I sit with them. I take my juniors resident. I talk to them in detail. Now, the whole negative connotation about death has to go away. Okay, because it is part and parcel of our life. Now, whether we can postpone it, we can do it when, as long as I told you, do minimal things, primary healthcare, take care of yourself, and live a ordinary, decent life. And when it time comes, you have something, accept it and get minimal care, whatever care you keep yourself comfortable. And you won't believe I am a critical care specialist. That means I have to be aggressively treating every organ system, and that is my specialty. But I actually a lifetime member of the Palliative Care Society of Trinidad and Tobago, and I do believe that even palliative care has to be incorporated into the critical care, and that is why I talk to the relatives. I tell them that this is what is the condition, despite all our efforts. Okay, it can happen. It's a question of time. Okay, all that we are now doing is toying with the biological parameters. We don't see a human being as a human being. How they are going to come out and be with, even if they sit on a wheelchair, okay, and interact with the family and be a reasonable quality of life, I can understand. But there are people who will be like completely like a vegetative state, or very critically ill. We will have a blood pressure over 70 over 40, and we will be pumping medications to bring up that number. Okay, so we will be treating these numbers as biological parameters, and we don't see a human being as a whole holistic human being who was walking with the flesh and mind and soul, or whatever you call it. And that part of it is missing in that particular type of treatment, aggressively treating individual organs. So that is what I see, the overall goal of what this patient is going to do after we reasonably give them a life after critical care unit. So that is what we have to see. So, but the current trend, again, as I told you, one is commercial driven. The second one is that litigation. If I don't do that, people are going to sue me. So these are things, fear, defensive practice. Third is, okay, I have my own colleagues who would say that let the patient be on the ventilator. My call is 24 hours. Let the next person come and decide whatever they want to do. So that is what is missing in the current healthcare provision. So what I do, I take chances. Once you see, we all are human beings, right? Once you talk to them and explain to them, they are going to, first they may deny. It's normal. Everybody, you are a psychologist, you know that. Denial is the first thing for everybody, patient or the patient relative. If you say that something is really seriously ill, they are going to deny it. Some people may be strongly denying until the end, and they'll say, I am praying, you do whatever you can do. Even they can be convinced. Now, what I would say is that, they will ask me the standard question is that, if it is your own mom or your own relative, will they do it? And I have the standard answer, yes. I did that for my mom because she had a stomach cancer, and she was in her end stage of life. And when I went there from here, and knowing that she is in the hospital, I went there. I said, we are not going to do anything in the ICU. I took her off the ICU, oxygen, everything. I took her in an ambulance to my village, home village, where we have our traditional house. And she was in coma for like two days or 2.5, 3 days, and then she passed away peacefully. I just kept her comfortable in my under my care in my traditional house, and it was, in my view, obscene to put her on a ventilator. I'm a critical care specialist. If I want to do, I could have done all that, but it is obscene to do that, because we know that death is imminent. Okay, so when we know that this is imminent and this is a natural process of life, we have to fold our hands and wait for the inevitable to happen. So that is where we have to now educate my juniors that way, that it's not that, oh, you don't need to feel guilty about it. That is another part. If they are being programmed to believe that if they don't treat that blood pressure, oh, they are actually missing something. They are not doing what they are supposed to do. They learned medicine to save life. Yes, save life, but what life? Life with a quality, not heart alone beating. That is not life. That is never a life. So we have to see human beings as a holistic person. How much reasonable quality of life we can give them. That is what I teach my students.
Yeah, and I think that if we were to speak to people, one of the things that I find is that we don't speak about death as much as you say it's inevitable. So you spoke about your mom. When my dad was actually diagnosed with lung cancer, I was the first person to know that. And I broke the news to him, actually. And I never forget his words. He said that, and he was a man of deep religious belief. He said, I am not afraid of dying. I just don't want pain. And I think as you speak to people, and I lost my own mom a couple of months ago, and she too was very aware that she would actually say, why am I on earth so long? I've lived beyond my time, and we'd almost joke about it. And I felt it was very important that we face it. And as you say, Prof, it also became, I recognize that as people get older and Alzheimer's and dementia and these conditions start to set in, what is it that they want? And it's something I want to ask you, what are the rights of the patients if they themselves are now not understanding what's going on with them? Like in the case with my mother, I mean, she was 88, but she thought her parents were alive. How do you deal with that? And I realized that, well, you will understand these situations far better than me, of course, is that there is no more learning happening. So we played along and that worked. And I actually thought, what was so terrible that she thought her parents were alive? And on the last day, she asked me, when are we going to India? And, so they go back like that. So back to the same thing that you're saying, there is that perspective, we must prolong life at all costs to what the patient and what the family is going through. And it appears to me that's not what that we need to perhaps re-educate ourselves. I mean, it's so complicated. There's religious aspects, there's the psychological aspects, there's a financial aspect. There are so many things. And then just humans losing someone you love. You don't even know. How do you deal with that? I mean, this is what you do. How do you deal with that, Prof? And that question that you actually sort of addressed, one talks about pulling the plug. Is that even legal in Trinidad? I have no knowledge about the legal aspects of what are the dying patients' rights. Could you tell us a bit about that, perhaps?
The thing is that we have the Brain Death Act, but it is in the context of a transplantation. If a patient is brain dead and they have valid organs to be harvested, so they can actually be counseled. The relatives can be counseled, and until the organs are harvested, okay, we can prolong their life. And after harvesting, we can actually withdraw the plug. That is what is pulling the plug. And they will die on their own, right? After that, after harvesting organs. But For a patient who is extremely ill, critically ill, we do not call it pulling the plug. We never pull the plug. What we do is that we do have a medical decision, what we call as DNR, do not resuscitate. This is a policy guideline. This is not a legal statute. There is no legal statute, but this can be defended by common law defense, like any other medical decision. So if the patient is a really, really very in very, very bad status, that whatever you do, it's just not going to bring back the patient to even a reasonable quality of life. That's what I was telling about from the beginning. So that will be decided by the consultant who is actually taking care of the patient, and there will be another additional consultant who will endorse it. That is in our NCRHA policy. As ethics committee chairman, we actually formulated the policy based on the national ICU policy guidelines. So the DNR, once we say the DNR, we do not aggressively provide any care for that patient. And we don't withdraw any patient, as you said, like we don't pull the plug or we don't withdraw any patient. We just keep them comfortable. But if the blood pressure goes down, we don't just go or if they suddenly the heart stops, we don't jump on them and do a CPR to resuscitate them. And that is what is do not resuscitate order. So they will eventually die. But this also actually we do not do unilaterally. We always talk to the patient relatives, and we will explain to them that they have reached a level that this is not going to make any difference in their life. It is going to only prolong their agony. And so when I explain that way, they know that their relatives don't want they don't want them to be in agony. So I when I tell them that, and then they understand, but we give them time, enough time for them to come to terms with that, and like 2 or 3 days, and then they be with the patient. They will hold their hand, and we are not going to actively resuscitate. We are not going to aggressively treat this patient. And I will tell you, most people, very few, I can tell you 1 or 2% of the whole population will be very adamant and say that no, we are not agreeing for the DNR. You have to do everything possible. We are praying and all that, but that is very minimal. People do understand. People do understand, and this is why I've been always emphasizing from my medical council days, from as a medical, I'm a teacher of young medical students and postgrads. Communication, effective communication is the key for all these things. We are all human beings. Okay, it's not that that only when we don't talk, they get suspicion. When you are transparent, when you talk to them, when you say that this is the exact status, and we are trying everything possible, but still there is no improvement, they are going to die. So but do you want the agony to be prolonged? And initially they may deny, and that denial will be always there, but eventually most of them will agree. So the rights is that when there is an invalid patient that way, the next of kin has the rights to decide. But in the Caribbean, it's a little more complicated. In India, we will know that next of kin is a son or a daughter or a wife or whatever. Here, when we have single common law people, and then sometimes we do have issues that two spouses will come and say that I am the real spouse, and then we don't have the exact evidence as to who will be the real spouse, and these are small complications which can come in. But we will ask them to provide the proper documentation to say that they are the next of kin, and then when they have the power to decide about these the so-called invalid patients. So that is the rights of the patients.
I'm going to ask a question. I don't even know if it makes any sense, but perhaps you could throw some light on it. Is natural death painful?
Something, this is very, very contextual. This morning, there is a Medscape article which actually they have published a paper on November 7th. What they did is that during resuscitation, they actually connected what we call as a EEG, electroencephalogram.
Yeah, from the
Yeah,
brain.
from the brain. So they will see the brain activity with the wave. So just released paper, it says that during the resuscitation, they found spikes of EEG that may correlate to the near-death experiences. But the EEG may not say that what will be the near-death experiences. But near-death experiences have been described in so many ways according to the culture and belief systems and so on and so forth. Some people see Jesus, some people see Lord Shiva. They go to Mount Kailash and then come back, and so many things will be described. But that depends on the cultural aspect of it. But there is definite brain activity, at least during the dying process, at least, and it is increased brain activity. Now, the thing is that, to answer your specific question about pain, okay, normal dying process is not painful as far as our current scientific evidence goes. Cancer, yes, it is painful, but the pain from the cancer is not killing them. Okay, it is there, but the cachexia, the consumption of all the tissues is what is killing them. But if a patient turns old and then becomes really emaciated and then they die, the dying process per se is not. And even trauma accidents where they get instantaneous death, there is not even time to actually experience any pain. So I don't think the dying process per se is painful, but the pre-death conditions can give a lot of pain, and that is why palliative care is very important. And that is, you rightly pointed out that in many countries, even for my own mom, I could not get proper narcotics in India because of the very stringent regulations. And from the colonial times, even here we do have that, what we call as a DDA, Dangerous Drugs Act. So the British people actually, they wanted to regulate all the narcotics, and they brought all these pethidine, morphine, and all these opioid under the Dangerous Drugs Act. And they may say that that is why they don't have these opioid deaths like in US. US, if you see the central areas of US in many provinces, actually there is decrease in longevity. That is the only place where in the whole world there is a decrease in longevity because of the opioid deaths. Because they got hooked, they get hooked up because there is a actually very free prescription practices of opioid. So that is the other extreme. And in one extreme, like in our British colonial countries, we have this Dangerous Drug Act, and it's very difficult to get opioids for even suffering patients. Trinidad is not bad. We do get morphine, we do get
Yes.
fentanyl, we do get pethidine, and then we do give we can keep them comfortable. And so palliative care is extremely important for the pain and the agony they experience before death, especially people who have crippling arthritis, people who have advanced cancer, and spinal problems. They name so many things are there which can be extremely painful. We have one or two interventional pain management specialists coming up. Anesthesiology, my subject, is actually closely related to pain management. So we get a special training for interventional pain management. Say, for example, my own mother had stomach cancer, right? If I would have had the equipment and the paraphernalia, I would have actually taken her to a center where I can actually see the nerve which is actually transmitting the pain from the stomach, which will be, cancer pain is really excruciating pain. And that is when, we actually block those nerves, or even actually we completely, uh, you know, we, what we call as a neurolysis, completely necrose that nerve. It will not transmit anymore. So there is something called a celiac plexus. We just completely destroy that nerve plexus so that they won't have pain at all. So there are other pharmacological opioid is there, and actually, to be honest, cannabis is also a very good pain medication. But the problem is that once we have decriminalized now, it has to go to the next level of actually extracting those tetrahydrocannabinol and the alkaloids, which can be given for this type of pains, which is very, very, very promising, actually, to be honest.
This is so engaging to hear it from you, all these things with regard to dying. Because in my personal opinion, I think we don't talk about it enough. We don't discuss it. We all seem to behave as if we will live forever. As a physicist, I mean, we could talk about probabilities and quantum mechanics, and there's always non-zero probability. But I think I have seen that death is 100% probability as we know it. All right. So I just want to ask you one or two more things. One reads about things like, and you perhaps have already covered it, death with dignity and dying on your own terms. What do they mean? And is it more like North American concepts, and or do we have that in Trinidad? I know you already spoke about the DNR, do not resuscitate, but is it any different from that?
Yeah, there is a difference, because dying with dignity is a very broad topic. It is not only North American; it is throughout the world, and there is a big movement now that that should be very dignified, and that many European countries, I mean, some Switzerland has suicide tourism, that, and then the physician-assisted suicide and physician-assisted death. I have reviewed many papers from even from US. US is, I must tell you that US is very conservative. They are not into all this physician assisted death, and in many states they are not still it's not legalized. Dying with dignity is extremely important, and it has to be taught to the young doctors, because again, as I told you, because of the defensive practice, because of the they are programmed to believe that if they don't save a life, if they don't
Yes.
keep the heartbeat going, they are not doing justice to what they learned as a doctor. But that is not true, and that has been my mission, that I have to tell them that yes, dying is natural. You cannot save every life, even though you are a doctor. Yes, definitely. You were programmed to believe that as much as possible, save lives, but you cannot save every single life. Like this is why I told you about my 5 years of post MBBS. That was rewarding, because I once I had some 300, 400 patients brought in a tractor. It was cholera, a
Wow.
cholera epidemic outbreak. Okay, and we those days we'd never had plastic IV fluids, so we just put in nails on the walls, and hung the glass bottles, and then with the steel needles, no cannula, nothing. So steel needles, and then flow the, I mean, like we were to flow the normal saline so much, and then we could save lives. That is saving life, because they wake up and then go away, be normal. The type of patients we now have to deal with, end stage cancer, right? And then see, for example, the lung cancer, right? Patient with an advanced lung cancer, they come, right? And then the surgeon wants to do some sort of what we call as a debulking. So they want to remove that tumor. So once they remove the tumor, because a major surgery, bleeding, so they land up in an ICU. Now the relatives see that, and see that at least now we don't have it yet in Trinidad, but in North American situation, they have something called a extracorporeal membrane oxygenation, ECMO. so which does the work of a lungs. Okay, so they just put them on the ECMO. Now, the whole blood is now diverted there. It gets oxygenated, the carbon dioxide is removed, and then it comes back to the patient. The patient is heart is beating, but the thing is that the lung is not functioning, and they do not have a reasonable quality of life, because once we stop the ECMO, they are going to die. Now, how long this ECMO has to be continued is a big topic there in US, because ECMO is now biting the third party payer whom I told you, the insurance. Insurance is not able to pay everybody who goes on ECMO. So they have now set up committees to say who has to go on ECMO. So these are things which are coming up. So when you put all these machines and hook up the patients before the inevitable happens, that is definitely not a dignified death. That is why I liked when you said, your dad said that I am not afraid of death. I have got something. Okay, fine, but keep me comfortable. I will die peacefully.
I have to say, I was very blessed. They were very blessed that both my parents passed away, surrounded by their family, holding their hands and praying as they breathed their last. And my father had actually refused chemotherapy. He did not want chemotherapy. Well, one of our close friends, medical doctors who was caring for him, managed to convince him to take some radiation treatment, which he did, but he was insistent he did not want chemotherapy for its things. And he went peacefully, and I know that peacefully and well, as did my mom. And I think for all of the people out there who are listening to us, I think it's a lot of personal decisions that people have to make, but we tend to be guided by professionals like yourself, Hari. So for me to hear you as a doctor be able to say a lot of the things that you've said gives me strength, gives me hope. I don't think anybody likes to see their loved one in pain, and the inevitable is going to happen. So is there a limit biologically as to how long humans can live? I mean, I do notice nowadays, people into their 90s, and the age that people are dying at is increasing slowly on average.
Yeah, it is increasing, but I must say that, it is, I don't know whether the quality of life has increased, number one. Number two, I will tell you, all these public health measures, hygiene, I told you about the longevity. In the 1700s, it was in the 40s and 50s, and we have reached to 70 now. Now, the high technology care, which I was mentioning you, critical care and all the high technology care, is only popular after 1990s. Okay. So if you see the curve of increasing lifespan, it had a leaps and bounds of 5 years, 5 years, 5 years, like that. It reached 1990. And from 1990, if you see, we are only gaining in decimals. That means to say that for this much of expenditure we do with the high technology care, we get decimals increase in the longevity in the lifespan. Okay, so that is very clear. And the 90s and 100s, there are many other factors, including genetic, background, and so on and so forth. But the thing is, what I wanted to say is that, the lifespan, I don't know if you watched this documentary about, in the Discovery Channel, the Mythbusters guy. He actually was in this particular documentary, and he lives for 3,000 years, okay? Hypothetically. But for every stage of prolonging his life, they actually quoted some sort of research happening in some part of the world, in Europe, in North America, in Canada. For example, the dementia part you said, right? So when his brain is started shrinking, what they will do, they will put in the stem cells into the brain, and then the brain will grow back again. So they will treating him like a collection of a biomedical organs, okay? And then each organ was taken care of by the research, and then this guy lives for 3,000 years, and at 3,000 years he says, I don't want to live anymore, don't touch me. I don't know why I am living. I don't have any of my whatever, my sons and grandsons and great, I don't know who it is. I have completely everything has changed, and this is not a place for me to live. And what am I going to do living there? So that opened up a very, a big, it was a real eye opener for me, because that is what is nature. Nature is recycling. You cannot live forever. Yes, we brought the lifespan from 50s to 70s, 80s, 90s. Fine. You and me are the fans of Yuval Harari, and he know that he is writing that the Homo Deus, that we
Yes.
can reach the level of godliness,
Gods.
and we can, yeah. But immortality is not possible. That is, I think it's against nature, because if you see the all the traditions, you are a physicist, and then I don't know if you know about Carl Sagan said about this particular thing which came in the Rig Vedas long back, when it said that there is no existence, neither existence nor non-existence, and there was no death, and there was no immortality. So this shloka in the Rig Veda says about the origin of the universe.
Yes.
So what I am trying to say is that the immortality, and as you rightly pointed out, the probability, immortality is not possible. It is not natural for recycling of everything what we have, whether it is a living being or even an inanimate object. Everything has to the matter has to recycle, and that is what we have to understand, that this universe, I mean, that is a so complex, and the multiverse is so complex, and we feel so actually proud that we got a little nano speck in this universe to understand this much. And that is what I will feel, and whatever is given to me by nature, I'll be happy with it. And to unduly prolong it and do nothing about it, my heart alone beating, and then I go with all my machines, and that is obscene for me. So I don't think philosophically, spiritually, scientifically, uh, physically, whatever you call it, immortality is a pipe dream.
Well, Harry, you're also a visionary because you sort of anticipated my last question and answered it already. I was going to ask you, if you could be immortal, would you choose it? But I think you gave the answer very clearly. So no need to answer. But at this time, I am going to release you. This has been so absolutely engaging. And folks, this is not going to be the end of it. We have just touched on some of the topics which are dear to all of us as humans, as humanity, that Prof has really shed a lot of light on. So this is just the first segment. So make sure and tune in for the second part of this continuing conversation on life and death, and everything that affects us so deeply as humans as we are. So Prof, thank you for
Thank you so much, Shareen.
sharing
I know
all this insight.
and I'm so grateful, because I've been waiting for opportunities to talk like this and spread the word, and youngsters, young medical doctors, lay persons, everybody, they must understand that everything has its limit. Critical care unit is not the high technology medicine, is not the answer, and that has been my mission. And I'm so grateful to you for giving this opportunity.
Thank you so much for joining us today. So, folks, for this episode, which we will have a second part to, I am your host, Shirin Hack. I'm signing off from none other than Studio 42, where we seek to find the answers to life, the universe, and everything. Bye.